Hello. This video is intended to help you meet the objectives of the Interprofessional Communication Workshop, and doing that by helping you to get a little more familiar with each of the disciplines that you're likely to encounter on interdisciplinary teams. So in this grouping today, they're represented each one from each of 6 disciplines. Unfortunately, we're missing occupational therapy, but we'll show you a way to learn about them at the end. We're going to ask each of the members from their discipline here today to tell you a little bit about their background and training, about the role that they play on interdisciplinary teams, and also about some of the myths and misconceptions that members of their discipline tend to encounter in practice. So we hope you will enjoy it and find it useful and interesting.
Hi, I'm here to represent the discipline of nursing, and maybe it's better if I start by talking about a couple of the myths, because it'll help to think about the training of nurses. And one, I think, of the most common myths are that all nurses are the same, that a nurse is a nurse is a nurse. And my sense is that what you will encounter in practice and in interprofessional meetings are some fairly wide varieties of nursing. So there are nurses trained in year-long programs that might be called licensed practical nurses. There are registered nurses who can be trained in 1 year or 2 years at an associate degree level. Registered nurses who generally these days are in a 4-year bachelor's program. And then there are advanced practice nurses who practice at an advanced level and work as nurse practitioners or clinical nurse specialists. So nurses aren't all trained in the same way, and sometimes it's difficult to navigate that in a team. And I think it's important to understand that when you're working with a team and think about what people's backgrounds are. On the other hand, all of those types of nurses generally spend a lot of time with patients. And so one of the things that you'll see in terms of the role of the nurse on the team is someone who can give you the perspective of a person who's there 24 hours a day. In most settings, except home care, but certainly in long-term care and in hospital settings, nurses are around all the time in some way or another. And so I think it's important to understand their perspective, and that because of that, they see things that other team members may not see, and they really need to be at the table, and they need to be part of an interprofessional discussion about plans of care. The other myth that I might just throw out there is that sometimes we hear that nurses have to be supervised by a physician or by some other healthcare provider. Registered nurses and advanced practice nurses work on their own license, so they don't have to be supervised by another provider. And I think what works best when we think about nurses as part of the team is that there's really that collaboration and understanding that nurses do have their own license and their own scope of practice, but that they are eager, I think, to work with other disciplines.
I'm here to represent the role of the social worker. The role of the social worker in a healthcare setting can vary greatly. There's often the role of health navigator, case management, discharge planning, or a combination of all different things. We're here to represent both the patient and the family. We're looking at how to cope with an illness or an extreme situation. We're also looking at resources for families and patients to get through certain situations. But we also work very collaboratively with other disciplines in the role of advocating for home support or social support at home, getting to know the patient a bit more, the family a bit more, and what we can provide in that situation. Our backgrounds mainly are MSWs, which requires a degree, advanced degree, and also training, clinical training. We also provide, help in other situations on a team. We are kind of the backbone sometimes with the patient and the family as a resource in many different situations. Everyone that becomes a social worker is required to get an MSW. After you achieve your MSW, you can get supervision and take a test and become an LSW per state. If you decide that you want to be a licensed clinical social worker, you then have to get about 2 years or 3,000 hours of supervision clinically, and then take a separate test and pass that in order to be a licensed clinical social worker, which allows you to be a therapist and to bill for that when you get approval.
Hi, I'm here representing the profession of medicine. Physicians on teams tend to offer their expertise about the medical diagnoses that may be affecting the patient's problems at any given time, what the treatments available might be for the team to consider, and sometimes what the prognosis is likely to be. In order to have that expertise, physicians go through a training program starting with medical school where they receive an MD or a DO degree. They then do 3 years of general training in one area of the field, like medicine or surgery or pediatrics. If the physicians wish to specialize, they'll undergo 1, 2, or 3 years of training beyond residency, which is called fellowship. One funny myth that I get asked by patients and sometimes by families is that what's the difference between an intern and an internist? So the first year of residency is commonly referred to as the intern year. An internist is a physician who's done 3 years of training in the field of internal medicine and is preparing to embark on a career where they're going to tend to the medical problems of adult patients. Thank you.
Hi everyone, I'm here to represent the profession of pharmacy. I'm going to take a page from my nursing colleague's book and start with some of the myths. So one of the major myths that pharmacists also get faced with is that we only know how to count by fives, or lick, stick, and pour. And that's traditionally because our rich history is in most of the community setting, and a lot of people, when they hear the word pharmacy, is what they think of naturally. Pharmacy, however, has progressed, and not only are we still serving in the community setting, where you may see us at your local CVS or hopefully mom and pop pharmacy, but now we're also expanding into our role on hospital floors and long-term care, as well as really any healthcare setting where we could serve as a medication resource, both to the healthcare team, of our other healthcare professionals, as well as patients and families. Training to get to this point is we go through 4 years of pharmacy school, and then there is the option to do a first year and also second year residency, which could specialize you into a particular field, taking from our colleagues in medicine. So the role of the pharmacist has really expanded from our dispensary functions within a community pharmacy to really serving as a medication resource for the team. And what this entails is a lot of it is being a counseling for both the patient, their family, as well as the medical team about the appropriateness of the medicine, adverse side effects of the medicine, as well as helping other healthcare professionals understand different evidence-based recommendations of the medicines, and really working with the team on the diagnosis if the medication is truly appropriate for the patient. We also serve as a patient advocate and really making sure that the patient understands how to take their medicines, counseling them on any potential barriers that they may have, as well as making sure that we communicate back to our team members if there's any problems that we uncover with the patient taking their meds, or any issues in medication problems between their home medicines and any medicines they're taking in a healthcare facility. And really this transition of the pharmacist gaining more responsibilities was really due to the change in education. And that's because traditionally in the past, up until about the mid-90s, pharmacists received what's called an RPH. So you may see those initials after some pharmacist's name, but now it's changed to a PharmD. And this expansion is really due to an extra year of schooling, as well as gaining a doctorate of pharmacy. And that has really allowed us as a profession to expand outside our dispensary role, get away from that common place of the basement where we typically used to hide. That's another myth, but really allow us to be involved in the team, serving our team members as really the drug expert, and hopefully getting across to the patient and their family as the ultimate outcome of how to appropriately take their medicines. So hopefully this was informing you a little bit more about the pharmacy profession and that we don't only count by fives.
I'm here representing the profession of physical therapy. Physical therapists are doctorally trained. We have 3 to 4 years of undergraduate work, followed by 3 years of physical therapy school, culminating in a clinical doctorate degree. Physical therapists are movement specialists, and we are in a variety of settings, from home care to outpatient to nursing homes and rehab facilities and acute care. And my comments will focus mostly on acute care, since that's what the workshop is also focusing on. In acute care, physical therapists are consulted for a number of reasons. One may be prevention of the known side effects of bed rest and immobility. Another reason you may consult physical therapy is to decrease someone's length of stay through early mobilization programs. Probably the most common reason a PT is consulted is to evaluate someone's function, their mobility. Do they have strength deficits or mobility deficits? Are they a risk for falls? Do they have cognitive deficits that may impact their ability to navigate an environment? So this is where a physical therapist can evaluate the patient and make some recommendations. Finally, I think physical therapists are an integral part of the team in terms of discharge planning in acute care, determining what is the optimal discharge plan to enhance this patient's outcomes. So physical therapists can recommend whether a patient needs continued physical therapy, needs therapy at home or in the outpatient setting, or maybe needs a referral to a rehab facility where they can get intensive treatment to restore their function. Another role that physical therapists play is determining the need for home equipment, assistive devices, durable medical equipment that can make it easier for the patient to manage at home or prevent falls in the home. And we can also visit the home as a home PT to really assess the patient's function in their own environment. I would say a top myth in the acute care setting as it relates to physical therapy is that physical therapists are there to just ambulate with patients. And this isn't necessarily true. While that may be part of our job, if the patient doesn't have any skilled PT needs, then that's not really a reason to consult physical therapy.
So I'd like to address the role of the chaplain on the team. Chaplaincy is a relatively new discipline in healthcare, at least in terms of being routinely incorporated on the team. But currently we talk much more about holistic healthcare. That is healthcare that represents all dimensions of the human person. And the spirit is certainly one of those dimensions. So chaplains are available to help staff and families and patients with that dimension. On the one hand, where spirituality is a strong resource in coping with illness or disability, the chaplain can support that and help other team members to see how to use it. Where the patient has perhaps spiritual distress, the chaplain can be a specialist to come in and address that and help make sure that it doesn't accentuate or make other problems of physical pain and disability even worse. There are a couple of myths that we encounter often as chaplains, and one of them is that we're only there to see religious persons. So that you come on the floor and someone says, oh, you should go see Mrs. So-and-so because she's very spiritual and she goes to church and that would be important to her. I think sometimes it's equally important that the chaplain be directed to people who are alienated from their faith or their spiritual resources, because we can help them reconnect with them. Another myth is that people often think that any chaplain should only go to patients of their own faith or particular religious background. Healthcare chaplains are trained particularly to be able to work effectively across faith boundaries. So it does not serve patients well necessarily to have that resource held from them because the chaplain is of a different faith background. That leads me into the training of chaplains. In order to become a certified chaplain in the United States, a person has to have an advanced degree, usually a Master's of Divinity, and in addition have 1,600 hours of clinical training in what is called clinical pastoral education. After that, they go in front of a board and present their materials and credentials and are interviewed to see whether or not they meet the standards for credentialing. It's something like physical therapy. If you have a patient who gets discharged to hospice, chaplains are often also found in hospice programs and can see patients at home as well. Okay, thank you. Okay, thanks for your attention to our various representatives of the different professions here. We hope you'll also go and look at the materials that are going to be provided online, the written materials that'll give you some more detail about the training background and scope of practice for each of the professions, and in particular for the occupational therapist who wasn't able to be with us today. We hope with this you're going to be better prepared to participate not only in the workshop coming up, but in team work and activity as you advance in practice. Thank you.